Hello, my name is Erin South, and welcome to the FDA Office of Women's Health Public Health Regulatory Series. We're also observing National Women's Health Week and National Osteoporosis Awareness and Prevention Month. Today's talk is titled Osteoporosis, a Perspective for 2024. Before we begin, I have a few announcements regarding continuing education credit for this activity. Speakers attest that the content they contribute is supported by the best available knowledge or evidence and gives a fair and balanced view of diagnostic and therapeutic options. They are reminded to disclose when products or procedures being discussed are off-label, unlabeled, or not FDA approved, and any limitations on the information that is presented. Our speaker reports the following relationships: Alexion Advisory Board, Amgen Research Grant. Our Planning Committee and CE Consultation and Accreditation Team report nothing to disclose. All of the relevant financial relationships listed for these individuals have been mitigated. The views expressed are those of the speaker and do not necessarily reflect official policy of the U.S. FDA. No official endorsement by the Office of Women's Health or U.S. FDA is intended or should be inferred. All inquiries for information should be directed to me, Erin South. All registered participants will receive a CE credit claiming code and claiming instructions by email within 24 hours after the seminar. All learners claiming CE credit must attest to their attendance and complete all required activity evaluations in the FDA CE portal at ceportal.fda.gov within 14 days after the activity ends. Upon completion, learners may view and print their statement of credit. Attention, NABP pharmacists and pharmacy technicians. The FDA CE team will report your credit to the NABP, provided you add your NABP ID and date of birth to your profile in the FDA CE portal. The only official statement of credit is the one that you pulled from the CPE monitor. If you do not see your credit reflected on CPE monitor after 45 days of attestation, please contact FDA CE team at fda.hhs.gov. The CPE monitor sets a strict 60-day limit on uploading credits. Closed captioning for today's webinar is available by toggling the button at the bottom of your screen. Throughout the presentation, you may type your questions for our speaker into the Q&A pod, and we'll address them at the end of the presentation as time allows. And now for some quick pre-poll questions. Which of the following patients is least likely to be at risk for, I think we've got the wrong question up on the screen. Which of the following patients is least likely to be at risk for osteoporosis or low bone density? A 65-year-old woman with rheumatoid arthritis and history of glucocorticoid use. B, a 25-year-old woman who takes levothyroxine for hypothyroidism, which is normalized for thyroid function tests. C, a 79-year-old woman with a history of Cole's fracture. D, a 45-year-old man with celiac disease. Or E, a 57-year-old woman with a history of stage 1 breast cancer taking an aromatase inhibitor. Please submit your response now. Okay, we'll bring up question 2. A 66-year-old woman has T-scores at the spine, total hip, and femoral neck of -1.1, -1.4, and -1.6. Her spine imaging shows 3 compression fractures. She was unaware of the fractures, denies any trauma, but recalls transient back pain 3 years ago after opening a window. Which is the next most appropriate step? Is it A, continue to monitor her bone density every 2 years? She does not require treatment because she doesn't have osteoporosis, and her FRAX estimated risk is 15% for MOF and 1.9% for hip fracture. B, evaluate for secondary osteoporosis and start treatment for osteoporosis with an anabolic agent if she has no contraindications. C, evaluate for secondary osteoporosis and start calcium, vitamin D, and an exercise program without prescription treatment for osteoporosis. Or D, evaluate for secondary osteoporosis and start treatment for osteoporosis with an anti-resorptive agent if she has no contraindications. Please submit your response. Okay, we will bring up our third and final pre-poll question. True or false? Most patients with an osteoporotic hip fracture receive appropriate pharmacological treatment to reduce the risk of a subsequent fragility fracture. True or false? Okay. We will close out, and that will conclude our pre-poll questions. I would now like to welcome our Associate Commissioner for Women's Health and Director of the Office of Women's Health, Dr. Kavita Vasisht.
Thank you so much, Erin, and welcome everyone. On behalf of the FDA Office of Women's Health, I want to thank you again for joining us today. As Erin mentioned, this week is National Women's Health Week, and it's really a special time of year where we spotlight key health topics to encourage all of us to prioritize our physical, mental, and emotional well-being. Therefore, this year, in honor of National Women's Health Week, we are focusing on bone health, and our theme is Know Your Bones. This is part of a broader initiative we have called our Knowledge and News on Women's Health Initiative. Bone health is vital to our overall physical health and quality of life at every age. Osteoporosis is a bone disease that weakens bones and increases our risk of fractures. Of the estimated 10 million Americans with osteoporosis, more than 8 million, 80%, are women. In observance of National Women's Health Week and National Osteoporosis Awareness and Prevention Month, we're really pleased to bring you today's webinar, Osteoporosis, a Perspective for 2024, which will be presented by Dr. Marcella Walker. She is a professor of medicine in the Division of Endocrinology in the Department of Medicine at Columbia University Irving Medical Center. Dr. Walker is a clinician and researcher. Her major research interests focus on primary hyperparathyroidism and using new imaging technologies to study osteoporosis and the effects of various diseases and medications on bone health. She is the author of over 80 original research publications, chapters, review articles, and editorials. She also serves as the associate editor for several journals, including Bone. Dr. Walker received her undergraduate training at Wesleyan University and her medical training at the Johns Hopkins University School of Medicine. She completed her residency in internal medicine at Johns Hopkins Hospital and her fellowship training in endocrinology, diabetes, and metabolism at the College of Physicians and Surgeons at Columbia University. She is board certified in both internal medicine and endocrinology. In addition, Dr. Walker holds a master's degree in biostatistics and patient-oriented research from the Mailman School of Public Health at Columbia University. Today, we're very honored to have her. She's going to discuss the current approach to assessing bone health, as well as preventing and treating osteoporosis. So Dr. Walker, thank you for participating today. The screen is yours.
Thank you so much for having me. Thank you to the FDA for the invitation. Okay. So the goal of this talk is to allow the listener to identify the causes and consequences of osteoporosis and understand the burden of disease, to discuss strategies to assess fracture risk and diagnose osteoporosis, to describe the options for prevention and treatment, and to define and explain the osteoporosis care gap. So on the right here, I have an image of a painting by Gustav Klimt. It's known as The Three Ages of Women. On the right, you see a young mother with her infant daughter. On the left, you see an older woman, and some of the effects of aging are obvious. You see the curved spine. This is due to osteoporotic fractures. And I'd like to tell you today that osteoporosis is not necessarily an inevitable consequence of aging. We know that strong bones are essential to optimal health and quality of life. However, bone disease is very, very common. 1 in 2 women and 1 in 5 men will have a fracture related to osteoporosis. However, recent scientific advances have allowed us to develop new therapies, and osteoporosis is treatable and fractures are preventable. So the skeleton has many important functions. As you know, it provides shape to the body and the ability to move. It protects our vital organs like the brain, heart, and lungs, and it's dynamic. It serves as the reservoir for calcium and phosphate, which are essential to many life processes. The structure of bone is really quite amazing. Here you see a long bone cut in cross-section. The inner compartment of bone is known as the trabecular bone or spongy bone. There's lots of little interconnections that make the bone strong. And then there's an outer shell of compact bone or cortical bone, and this bone is very strong. So the structure of the skeleton allows it to be strong, yet also light. The major protein that composes bone is collagen, and several molecules of collagen come together, wind around each other, and they are then arranged as fibrils. And these fibrils are mineralized with calcium and phosphate, and then are arranged in a way that really optimizes bone strength, and it prevents, to some extent, the propagation of cracks. So ultimately, bone has a similar compressive strength as steel, but it's as light as wood. It adapts to use, and it's able to repair itself. There are three main types of bone cells. There are osteoclasts. These are shown here. These are the bone breakdown cells. Then there are the osteoblasts. These are the bone building cells. These cells lie down collagen, and then they mineralize it. And finally, we have osteocytes shown here on the bottom. Osteocytes are actually mature osteoblasts that have become embedded in the matrix that they've secreted, and then they're connected to one another in an intricate network. And they are the mechanoreceptors and transducers. So they're picking up on mechanical changes in the bone and then responding to it. And bone at various places is being broken down and rebuilt across the skeleton at different times. The process by which osteoclasts break down bone is known as bone resorption. After the excavation of old bone that's no longer healthy, then osteoblasts come in and they begin to get activated in the stage of reversal. And then they begin to lie down new collagen in formation, and then that collagen is mineralized. And so ultimately, the adult skeleton is replaced about once every 10 years. So in order to balance bone resorption and bone formation, the two cell types, osteoclasts and osteoblasts, they need to talk to each other. And they do this through proteins. The osteoblasts secrete a protein known as rank ligand. This binds to a receptor on the osteoclast called rank. And the interaction causes the osteoclast to become activated and resorb bone. On the other hand, another protein known as osteoprotegerin, or OPG, interferes with the interaction. And finally, a protein known as sclerostin inhibits bone formation. So how much bone resorption is present depends on the ratio of rank ligand to osteoprotegerin. And the more rank ligand that is present, the greater the bone resorption will be. The amount of bone does change over our life cycle. Here you see a graph of age plotted against bone mass, and women are shown in blue, men are shown in gray. And what you'll see here is in childhood and adolescence, as the skeleton grows linearly and it undergoes modeling, bone mass increases. And we hit the highest bone mass that we will ever have, known as peak bone mass, around age 25. Thereafter, bone density stays stable for a number of years. But for women, as they approach menopause and estrogen levels start to dwindle, bone resorption increases. And there's a period of very rapid bone loss after menopause for about 5 years. The rate of bone loss then slows, but it continues for the duration of our lives. For men, Men on average have a higher peak bone mass, and they do not have the equivalent of a menopause. And so the rate of bone loss in men is much slower and more gradual with aging. So men ultimately are less likely to develop osteoporosis. So what is osteoporosis? This is a condition that's characterized by low bone mass, microstructural deterioration, and loss of bone strength. In this picture, you see the internal structure of a normal bone, and you can see there's lots of interconnections, and those connections are very thick and strong. On the other hand, you have a picture of a bone with osteoporosis. And what you can see is there's a lot of thinning of the interconnections and loss of those interconnections. And so that bone is very fragile. And importantly, as this process is happening, there are no symptoms. There are no symptoms that occur until the first fracture happens. So this condition predisposes to what we call fragility fractures, or fractures that happen with no or very little trauma. And when one has osteoporosis, you can break almost any bone in the body, but there are certain fractures that are more common. The most common type of fracture is a vertebral compression fracture. So when the vertebrae break as a result of osteoporosis, what happens is they compress, as you see in the picture. So there is height loss, and that's what causes kyphosis. The second most common type of fracture is a wrist fracture, followed by hip and pelvis fractures. And osteoporosis is quite common. So 10 million Americans have osteoporosis. Another 44 million have the precursor, low bone mass, or osteopenia. So together, this encompasses 54 million people, which is actually more than the number that have uncontrolled hypertension or uncontrolled hyperlipidemia. And ultimately, this leads to 2 million new cases of osteoporotic fracture per year. And this exceeds the annual number of cases of MI, breast cancer, and prostate cancer combined. So for a woman who's age 50, her chance of having a fracture related to osteoporosis in her lifetime is 50%. This compares with a 12% risk for breast cancer. For men have a 20% risk of fracture, and this compares to 17% risk for prostate cancer. The rate of fracture is not equal by race and ethnicity. This is data from the Women's Health Initiative study, which compared the incidence of hip fracture by race. And you can see the risk of hip fracture was highest in non-Hispanic white women and Native American women, and lower in African American and Mexican American women. However, it's important to note that people of all races and ethnicities can develop osteoporosis. They may not follow group patterns, and therefore we need to screen everyone if they meet criteria based on age and other risk factors, which we'll cover in a moment. Hip fractures can really be very serious. So about 20% of people will die within a year of having a hip fracture. 30% will have permanent disability. 40% will be unable to walk independently, and 80% will be unable to carry out at least one activity of daily living independently. So truly, hip fractures can be devastating. Spine fractures as well are very serious. They can cause back pain, loss of height, the kyphosis that we've mentioned before, reduced lung function, and they can diminish quality of life. Many people lose self-esteem, they have a distorted body image, they can become dependent on pain medication, have trouble sleeping, become depressed, and lose independence. Unfortunately, the mortality and morbidity is not equal after fracture. So this particular study compared different outcomes, death, disability, and destitution in Black and white women after having a fracture. And what you can see is death, which is shown in green. The risk of death was higher in Black women after a femur, hip, or humerus fracture. Similarly, the risk of being disabled was higher for Black women after a femur or hip fracture, and the risk of becoming destitute was higher for Black women after all types of fractures. So we really need to make aggressive efforts to understand these disparities and correct them. And we can't forget about men. Although osteoporosis is less common in men, they're often overlooked completely and not screened, and men have a higher mortality than women after fracture. So the economic toll of osteoporosis is truly enormous. Today, there are 2 million incident fragility fractures in the US at a cost of $57 billion. And by 2050, it's estimated that with the aging of the population, there will be 3.2 million incident fractures each year at a cost of $95 billion. So why does osteoporosis happen? I showed you a similar curve earlier, plotting age against bone density or bone mass, and we spoke about peak bone mass. The potential peak bone mass which somebody can achieve is mostly dictated by genetic factors, but the actual peak that someone achieves is influenced by lifestyle factors. These include things like calcium intake, vitamin D intake, dairy, exercise, medicines, and medical conditions. And so if lifestyle factors are poor, or there are certain diseases that develop during adolescence, or exposure to certain medications, someone may never achieve the peak that they were genetically destined to achieve. And then at the other end of the age spectrum, we all lose bone with aging, but healthy lifestyle behaviors can help slow that bone loss that happens with aging. So what are the risk factors for osteoporosis and fractures? Female sex, being postmenopausal, older age, a prior fracture, particularly a recent one, and we'll get into that more in a moment, certain medications, particularly the glucocorticoids, falling is a risk factor for fracture, being underweight or low weight works against you and is a risk factor, having low calcium and vitamin D intake, smoking, excessive alcohol use, physical inactivity, certain medical conditions, being immobile, and having a parent who had a hip fracture is a risk factor for the progeny. So I want to just touch on some of these individual risk factors a little bit more in depth. And age is a really important one because it's an independent risk factor for fracture apart from bone density. This graph indicates that the lower the bone density, which is shown in T-score here, the higher the risk of fracture. However, what you'll notice is that for a given bone density, and let's choose minus 2.5 here, the risk is much higher in somebody who's age 80 than age 50. I also mentioned prior fracture. So this particular study looked at the risk of fracture over time, and it divided people at baseline to those who'd had a previous vertebral fracture and those that didn't. And the prior fracture are shown in the solid line. What you'll see is that the risk of hip fracture and other non-vertebral fractures was much higher in people who had a prior vertebral fracture. I also mentioned the idea of a recent fracture, and this is the concept of imminent fracture risk, meaning that a recent fracture is associated with a higher risk of future fracture than a remote fracture. This particular study looked at the relative risk of a second hip fracture after a first hip fracture. And what you see is that the relative risk is astronomically high in the first 3 to 6 months, and then it dissipates, although it does not reach 1 until 10 years out. And so we want to think about fractures in much the same way we think about heart attacks. A fracture is a bone attack, and timely intervention is the best way to prevent the cycle of more fractures. I mentioned different medications and medical conditions that could affect bone health. This list is not comprehensive, and I can't go into all of them, but I'll just mention a few of the more common ones that are highlighted in orange. So overactive thyroid, diabetes, malabsorption, vitamin D deficiency, glucocorticoids, Rheumatoid arthritis and kidney disease are common secondary causes of osteoporosis. So in the field of osteoporosis, the main goal is to prevent future fractures. And so we have to identify people who are at high risk. How do we diagnose osteoporosis and identify those at risk? So DEXA, or dual energy X-ray absorptiometry, is the gold standard for assessing bone mass and fracture risk. And it's really important because this technology has been shown to predict future fracture. The concept of DEXA is pretty simple. Essentially, it measures how much X-ray passes through a bone and converts it to a density measure. It's fast. It takes about 10 minutes. The radiation exposure is low. It's inexpensive, and it's widely available. When we measure bone density, we get a raw density number in grams per centimeter squared, and then this is converted to a T-score. The T-score is a comparison to the mean for young adults at peak bone mass, and a T-score of -2.5 or lower in a postmenopausal woman or a man age 50 or over is consistent with osteoporosis. The Z-score is a comparison to age-matched peers, and this is used to assess bone health in younger individuals. The relationship between bone density and fracture risk is very powerful. This graph shows you bone density as T-score. And you see that for every 1 standard deviation decrease in bone density, fracture risk doubles to triples. So we consider a bone density or T-score of -1 or above as normal, a score of -1.1 to -2.49 as osteopenia or low bone mass, and a score of -2.5 or lower as osteoporosis. So who should we be screening? There are guidelines from various bodies. However, commonly accepted criteria for who should be screened are women age 65 and older, men 70 and older, younger adults who have clinical risk factors, adults who fractured after the age of 50, and adults with conditions or taking medications that can cause low bone mass or bone loss. So I've showed you that the lower the bone density, the higher the risk of fracture. But what's important to recognize is that that most fractures occur actually in people who have T-scores greater than -2.5. So that's shown here in this aqua line. This is the number of women with fractures in a particular study. So most of the fractures were actually happening in women with osteopenia. And this is because there are many, many more people with osteopenia than osteoporosis. So it's important to be able to identify individuals with osteopenia who are likely to fracture. And one way we can do this is by using FRAX, or the Fracture Risk Assessment Tool, which is available online. And what this tool does is it uses clinical risk factors to identify those at high risk for breaking a bone. It basically gives a 10-year probability for major osteoporotic fracture and hip fracture. Major osteoporotic fracture includes hip, spine, wrist, and humerus fractures. And in the United States, we consider high risk of fracture as a major osteoporotic fracture risk of 20% or greater and hip fracture risk of 3% or greater. So here I have plugged in, as an example, an 82-year-old woman who weighs 125 pounds and is 5'2". You can see that her hip T-score is -2.1. It's in the osteopenic range. But when we calculate her 10-year probability of fracture, her risk of hip fracture is actually quite high. It's 5.1%. It's above our threshold. And so this is somebody we would want to treat. In addition to bone density, DEXA can also assess trabecular bone score. So this technique assesses bone microstructure from the DEXA image, and it's been shown to predict fracture independently of bone density. It was FDA cleared in 2012, and it's covered by Medicare. So what is TBS? So the concept is pretty simple. Here you see a spine bone where the trabecular structure is pretty intact. And this is going to give us a high TBS score associated with stronger bone. On the other hand, if the internal structure of the vertebra are deteriorated, this is going to give us a lower TBS score that's associated with weak bone. How do we use this score? There's two main ways it can be utilized. The machine can give you TBS adjusted T-scores. So here's an example of that. This individual had T-scores in the osteopenic range, but you see the TBS was degraded. And so the machine adjusted the T-scores for the TBS score. And now they're downgraded, and some of those are in the osteoporotic range. Another way that TBS can be utilized is to plug it into the Frax algorithm. So there is a little button after you have calculated your fracture probability. You can click on Adjust with TBS, plug in your TBS number, and it will give you an adjusted fracture risk estimate. So we can diagnose osteoporosis in different ways. We can diagnose it based on T-score, based on fracture probability, or the presence of a fragility fracture of the spine, hip, pelvis, or another major bone. And that's regardless of T-score. So it's very important to know about fragility fractures. And while you might think it would be obvious from somebody's history, certain fractures aren't, and those include vertebral fractures. So one thing we might think about doing is vertebral fracture assessment, or VFA. VFA is basically an X-ray done on a DEXA machine. And we might think about doing this because vertebral fractures can be asymptomatic and undiagnosed. They can happen spontaneously without trauma. Many people don't know they have them. And it could change our diagnostic classification from osteopenia to osteoporosis, and it may change our treatment decisions. VFA is more convenient than a standard spine film. There's less radiation and lower cost. We want to think about getting this in people who've lost 1.5 inches of height or more, or if there's another reason to be suspicious for vertebral fracture. Not every DEXA center offers this, and so if you can't get it through your DEXA center, you can always refer somebody to get standard spine radiographs. So after we have all our information from our history and from our clinical risk factors, DEXA, our Frax estimate, what we want to do is risk stratify somebody. And so we want to determine whether they are very high, medium, or low risk. And different guidelines put out different criteria. They don't all agree, but most agree that if you have a T-score in the osteoporotic range and fragility fractures, you're very high risk. Or if you have multiple fragility fractures, a recent fracture, a very low T-score defined as a T-score of -3 or less, a fracture while on treatment or on harmful drugs, you're very high risk. High risk is considered a T-score in the osteoporotic range, a prior hip or vertebral fracture, or a Frax risk greater than 20% or 3%. And then if you don't meet those criteria, you are either medium or low risk. So after we exclude causes of secondary osteoporosis, we want to treat women and men age 50 and older who are at high risk. And these include people who have a clinical diagnosis of osteoporosis by virtue of a hip or spine fracture, or a diagnosis based on DEXA. We also want to treat people with osteopenia who are at high risk. And regardless of whether we're going to use a prescription medication or not, we also want to counsel patients regarding lifestyle and prevention measures. And so I'm going to touch on that a little bit first. So on the screen, I'm showing radiographs of the forearms of a professional right-handed tennis player. And you can immediately recognize, even by X-ray, that the right arm bones are much bigger and more dense than the left. So this is known as Wolff's Law. So the bone responds to mechanical loading. And so it makes sense that exercise might be helpful to bones. And we can use exercise to help prevent osteoporosis or as an adjunct to pharmacologic therapy in those who have osteoporosis. However, important to remember, exercise may not be safe in all, and you might have to modify what you recommend. Exercise alone is not sufficient to treat established osteoporosis. Really, the maximum effect of exercise is probably on the order of 1 to 3%, and that depends on the intensity, frequency, and duration of the exercise. The exercises that affect bone the most are progressive resistance training, weight-bearing exercise, impact exercises. And while I mentioned that there is some data to indicate a small effect on bone density, fracture data are lacking. If you'd like more information on exercise and bone health, the International Osteoporosis Foundation has a very nice website called buildbetterbones.org, and you can go there for some really good information. Another important thing to consider is falls, and it's important to counsel patients regarding fall risk reduction. We can recommend balance exercises. We can also prescribe physical therapy. It's important to counsel patients to remove hazards from their home, like anchoring rugs, minimizing clutter, using non-skid mats, handrails, lighting stairs, making sure you're wearing good shoes, reducing or eliminating medications that might cause someone to fall, and correcting vision. Also important to counsel patients to stop smoking, stop excessive alcohol use, maintain a healthy weight, and also minimize the use of medications that can cause bone loss. What about calcium and vitamin D? So as I mentioned, bones are mineralized, and vitamin D increases the intestinal absorption of calcium. So some calcium is lost every day in normal bodily processes through the GI tract and through urinary excretion. And so we need to replace some of what we've lost. How much is a bit controversial. The Institute of Medicine and National Academy of Medicine recommend 1,000 to 1,200 milligrams of calcium a day, depending on age and sex, and 600 to 800 units of vitamin D each day. And ideally, it is best to try to get this from diet if it's possible. And so you need to know what foods are most rich in calcium. Dairy has the most concentrated amount of calcium, but you can see there is calcium in non-dairy foods as well. And important to know how to interpret food labels so that you can calculate how much calcium you're getting in milligrams. Calcium is listed as a percentage on nutrition labels, and if you multiply the percentage by 1,200, you will get the milligrams of calcium. So what about supplements? The efficacy of calcium and vitamin D supplements to prevent fractures is very controversial. A large study, the Women's Health Initiative, randomized women to 1,000 milligrams of calcium and 400 units of vitamin D. And you can see here the results were a bit disappointing. Placebo shown in blue, calcium in the purple. And there was no difference in the risk of hip fracture. There was a small improvement in hip bone density. In post hoc analyses, different subgroups were analyzed. Those who had at least 80% adherence to placebo or supplements, in that particular group, there was a benefit for hip fracture. And it was observed that calcium and vitamin D supplements do slightly increase the risk of kidney stones. There was no increased risk of mortality. One limitation of this study is that the average calcium intake at baseline was actually quite high. Another recent study known as the VITAL study randomized women to 2,000 units of vitamin D and showed no benefit in fracture risk reduction. Another limitation there was that the vitamin D level at baseline was actually in the sufficient range. From these studies, though, I think we can conclude that in healthy adults who have sufficient dietary intakes, we don't need to recommend supplements. Meta-analyses of many different trials have shown that there may be a benefit of the combination of calcium and vitamin D in particular groups. Those include people who are deficient and in elderly who are institutionalized in nursing homes. And so I think you can consider supplements if somebody has osteoporosis and they are not meeting their requirements from diet. You certainly don't need supplements if the diet is sufficient. You don't want to over supplement. More is not better. So now I'm going to turn to prescription medications. And when we think about prescription medications, there's two main categories that we think about. The first is anti-resorptives, and the second is anabolic agents. The anti-resorptives inhibit osteoclasts. They do increase bone density, and they reduce the risk of fracture. These medications include the bisphosphonates, alendronate, risedronate, abandronate, and zoledronic acid, as well as denosumab, estrogen, the selective estrogen receptor modulators, and calcitonin. The anabolic agents stimulate osteoblasts to make bone more quickly. They increase bone density, and they also reduce the risk of fracture. These include medications like teriparatide and abaloparatide. And more recently, we have one agent that is considered a dual agent. This is a medication that stimulates bone formation and reduces bone breakdown. There's only one member in this category, and it's romosozumab. Okay, so medications work in different ways. Denosumab works by interfering with the interaction between rank and rank ligand that I mentioned before. The medications abaloparatide and teriparatide are PTH receptor agonists. These act like parathyroid hormone, a hormone that our body normally makes, which controls bone metabolism. Romosozumab is an anti-sclerostin antibody, so it interferes with that protein sclerostin that tamps down bone formation. The selective estrogen receptor modulators in estrogen, they reduce rank ligand levels. And finally, the bisphosphonates, they bind to bone mineral, they're taken up by osteoclasts, and they reduce their absorptive capacity. And so here I have listed FDA-approved medications for the treatment and prevention of osteoporosis. You can see that they come in different forms and routes of administration. Some are oral, some are intravenous, some are subcutaneous, some are intranasal. And importantly, all of them have been shown to reduce the risk of vertebral fracture. Some, but not others, also have been shown to reduce hip and non-vertebral fractures. So in the field of osteoporosis, there are very few head-to-head trials of one medicine against another, but some really important data that has come out recently is data from the FNIH bone quality study. In this analysis, patient data from over 61,000 participants in 16 different randomized clinical trials was pooled. And what was analyzed was what was the fracture risk reduction based on how much bone density changed with treatment. So what you can see looking at this thick black bar here is that the more a medication increases bone density, the greater it reduces the risk of fracture. And stated differently here in this table, you see if a medicine increased bone density by 2%, there was a 28% reduction in vertebral fracture, 4%, a 51% reduction, 6% increase in bone density, a 66% reduction in vertebral fracture. And medicines were also analyzed by class to see which ones increased bone density the most and which reduced the risk of fracture the most. What you can see is the anabolic agents and denosumab had greater percent difference change in bone density, greater fracture risk reduction. The SERMs, the selective estrogen receptor modulators, had the weakest effect to increase bone density and the least reduction in fracture. And then bisphosphonates fell in between. Those are shown in orange. And so that knowledge is important to choose the right treatment. I talked about this fracture risk stratification before. And so When we categorize people as low or moderate risk, usually we're not treating them with a prescription medicine. Usually for those people, non-pharmacologic treatment suffices. In some instances, we might use medications like bisphosphonates to prevent osteoporosis. Now, on the other hand, people who are very high risk, various guidelines recommend anabolic agents as first-line therapy for these very high risks, or alternatively, denosumab or IV bisphosphonates. For people that are high but not very high risk, bisphosphonates are usually the first-line therapy. Denosumab is an alternative in those who can't use bisphosphonates. And so why are these anabolic agents recommended in people who are very high risk? So this particular study did compare an anabolic agent with an anti-resorptive head-to-head. So teriparatide is shown in blue and risedronate in red. And what you can see is that there was a greater reduction in vertebral fracture with teriparatide than risedronate, both at 12 months and 24 months. And the time to first fracture was extended with teriparatide. So teriparatide started working more quickly. There's other data comparing anabolics and anti-resorptives that I don't have time to get into, but also shows superiority of anabolics in very high-risk patients. For these very high-risk patients, the sequence of treatment is also important. So there's data to indicate that anti-resorptives blunt the effects of anabolics. Here we're looking at the average change in lumbar spine bone density with romosozumab. If it's used before alendronate or before denosumab, the average change is about 13%. On the other hand, if it's used after alendronate, there's only a 9.8% increase in bone density. Similarly, with DMAB, if it's used after DMAB, there's only a 5.3% increase in bone density. So the anti-resorptives do blunt the effects of anabolics. So that's important to recognize. Don't have time to show you this data, but it is essential to follow any anabolic therapy with an anti-resorptive to maintain the gains in bone density. There's not much data about using anabolics in sequence. Theoretically, we think this is probably okay. And then there's some data about using anti-resorptives in sequence and some information to indicate that if you use a more potent anti-resorptive following a less potent one, you can get further increases in bone density. So one question that comes up quite frequently is how long do we treat with the bisphosphonates? This is controversial. The optimal length of therapy is not clear because these medications are retained in the skeleton after they're stopped. There's a lot of data to suggest that 3 to 5 years of therapy is safe for most patients, but long-term data is limited and some of the side effects are related to length of treatment. So different guidelines from the Endocrine Society and ACE recommend that after 3 to 5 years of treatment, we reassess fracture risk. And for people who are no longer at high risk, we can consider giving those people a drug holiday. On the other hand, if somebody is still at high or very high risk, then we might treat them longer, up to 6 to 10 years, or we might consider changing therapy. So I mentioned side effects, and one that's gotten a lot of attention is osteonecrosis of the jaw. This has been observed with bisphosphonates and denosumab. What it is an area of exposed bone in the maxillofacial region that doesn't heal after 8 weeks. And it might happen after an invasive dental procedure like a tooth extraction or an implant. The risk is very low. It's estimated to be less than 0.02 to 0.05% for bisphosphonates, similar risk for denosumab. Risk factors include poor oral hygiene, glucocorticoids, chemotherapies, and then invasive dental procedures. It's not clear whether holidays from drugs or waiting before doing these procedures reduces risks, but some clinicians do this. Another adverse effect that's gotten a lot of attention are the atypical fractures. These are particular femoral fractures that have a certain radiographic appearance. The incidence is low, but it does increase with greater cumulative therapy. And incidence may be higher in certain racial and ethnic groups, for instance, people of Asian descent. However, for the general population, there's still a favorable benefit to risk ratio. Less than 1 atypical fracture occurs for every 100 fractures prevented. And then what are some of the adverse events that have been reported with the PTH receptor agonists? So in preclinical studies in rodents, osteosarcoma was observed. This led to an initial black box warning from the FDA. However, post-marketing data over 15 years was examined, and there was no increased rate observed in humans compared to background rates. And so the FDA removed warnings from some of these analogs. We still do avoid them in people at increased risk for osteosarcoma. And then romosozumab, our newest medicine, this has a black box warning about a possible increased risk of MI, stroke, and cardiovascular events. So unfortunately, because of these very rare events, many patients are terrified to take these medications. And what you see in these graphs is the prevalence of bisphosphonate use in the 1990s and then 2000s. And you can see use peaked around 2007, 2008. And after some of these reports of rare side effects came out, the use really dropped off. And this was true even in people who've had the most devastating consequence of osteoporosis hip fracture. You can see there was a high of 9.8% use in 2004, and then down to 3.3% in 2015. And so hip fracture rates were declining in the US. Unfortunately, this is no longer declining in parallel with the decreased use of medication for osteoporosis. And so that downward spiral of multiple fractures and loss of independence and premature death that we thought we had conquered is potentially now going to become more common again. Okay, and so I want to try to put some of those rare events into perspective. This graph shows the incidence of various rare side effects against other events. So you can see that the risk of osteonecrosis of the jaw is actually less than the risk of dying by murder or in a fatal MVA. Similarly, short-term bisphosphonate use is associated with a very low risk of atypical fractures. Risk does go up with long-term use, but still very low in comparison to the risk of having an osteoporotic fracture. And this is true even in women who are low risk. And so really the benefits of these medications outweigh the risks in people who are high risk or very high risk. And unfortunately, we have an osteoporosis care gap, which is a disconnection between what we know should happen to patients and what actually does happen to patients. Fewer than 25% of women with a fragility fracture get a DEXA, and fewer than 20% of patients with fragility fractures are actually treated for osteoporosis. And so I think there's some opportunities to re-educate the public and healthcare providers. We want to also take advantage potentially of something that's going to become increasingly popular, which is opportunistic screening for osteoporosis. That's the idea of using clinical scans, either CT or X-ray, to try to diagnose osteoporosis. There are opportunities to use artificial intelligence and the EMR to remind patients and clinicians about screening and treatment. The Holy Grail, of course, is a therapy that would cure the condition. We don't have that right now. And then possible new therapies that are being studied. A new device was recently FDA cleared. This is called the OsteoBoost, and it's a wearable vibration device which slowed bone loss. And then things that are studied but not yet FDA approved are PTH receptor agonists in other forms, not subcutaneous, but oral, transdermal, other sclerostin inhibitors, local osteoenhancement procedures, which inject material into the hip bone to make it stronger. There's also active research in senolytics and beta blockers. And we also need more data about the order of therapy and combination therapy. And so in summary, osteoporosis is a disease that can be prevented and treated. It's very common. Hip fractures and other types of fractures can have very devastating consequences. It's silent. You need to get screened to know you have it. The fractures are preventable, and treatment is available, and it's safe for people who are high or very high risk. So thank you.
Thank you, Dr. Walker, for an excellent presentation. Before we get into a couple of Q&A, I just want to quickly bring up our post poll. We could please just bring up our first post poll question. It should be showing on your screen. Which of the following patients is least likely to be at risk for osteoporosis or low bone density? Please submit your responses, audience. And the correct response is B, a 25-year-old woman who takes levothyroxine for hypothyroidism, which has normalized her thyroid function test. Great. We'll bring up our next post-poll question. A 66-year-old woman has T-scores of the spine, total hip, and femoral neck of -1.1, -1.4, and -1.6. Her spine imaging shows 3 compression fractures. She was unaware of the fractures, denies any trauma, but recalls transient back pain 3 years ago after opening a window. Which is the most appropriate step? And the correct response is B, evaluate for secondary osteoporosis and start treatment for osteoporosis with an anabolic agent if she has no contraindications. And our third and final post-poll question, true or false? Most patients with an osteoporotic hip fracture receive appropriate pharmacological treatment to reduce the risk of subsequent fragility fracture. And the correct response is false. Okay, a lot of correct answers there. So thank you. And we've got time, I think, for a couple of questions. Our first question, Dr. Walker, can PPIs, proton pump inhibitors, increase fracture risk?
Great question. In epidemiologic studies, there is an association between PPIs and increased risk of fracture. There really isn't any data from randomized trials. And so important to remember that PPI users are different than people who don't use PPIs, and it's not clear if it's the PPI itself or perhaps comorbidities and other medications that are taken at the same time. Because it's controversial and not known, and in theory has, the idea is that the PPI might block acid production and interfere with the absorption of calcium. What I usually tell patients is, try to use the lowest dose for the least amount of time possible. But there's certainly patients who need these medications chronically. And if so, you should take them.
Thank you. The next question, do you think patients should be routinely screened for atypical fractures?
Great question. So I don't think it necessarily makes sense to screen all patients on bisphosphonates and Prolia for atypical fractures. Certainly, if somebody has pain or reason to believe they might have an atypical fracture, we want to get imaging. For people who have been on longer term therapy, we might consider getting screening. And in some DEXA centers, you can do extended femur scans that can help look for those atypical fractures.
Thank you. I think we've got time for 2 more here. Can you speak to how to manage calcium supplementation while managing cardiovascular risk, especially in postmenopausal women? And on top of that, is there any role for monitoring vitamin D levels during pregnancy?
Okay, so the calcium supplement question. So it's controversial whether calcium supplements increase cardiovascular risk. There were some meta-analyses that suggested using calcium supplements was associated with an increased risk of heart attack or cardiovascular death. However, important to remember that in the trials that were included, cardiovascular events weren't like a pre-specified endpoint. They weren't adjudicated. So it really isn't clear. So I think it really comes down to deficiency. You have to remember the skeleton is the reservoir for calcium. Calcium is essential mineral. If your body is deficient, it's going to take calcium from the skeleton. So if you're deficient, I think it's safe to take supplements up to that 1,000 or 1,200 milligram limit without putting yourself at undue risk. Yeah. Vitamin D levels during pregnancy. Well, I think it's sort of controversial whether to measure vitamin D levels at all during pregnancy, specifically, probably even more controversial. I don't know that there's good data to base an answer on. I think, you find in clinical practice, although there isn't robust data to support this approach, many people who treat osteoporosis will measure vitamin D level and adjust intake to achieve a D level of 20 to 30 or greater, with an upper limit, somewhere around 50. And this is particularly important in people who are being treated with some therapies for osteoporosis, because some of those therapies, a side effect that I didn't have time to get into is a reduction in the serum calcium level.
Thank you. That's great to know. Thank you. And we are at time, so we want to wrap it up by saying thank you to our speaker, Dr. Walker. We appreciate your expertise and the amazing work that you've done. And we also want to thank our audience today. This concludes our presentation. The link to the recording will be shared with all of the registered attendees within the next 2 to 3 weeks. Thank you, Dr. Walker. This was fabulous. Thank you for all of the information.
My pleasure. Thanks for inviting me.
Thank you. And this concludes our presentation today. Goodbye.